Hello, my name is Dr. Dave Larsen. I am an epidemiologist and an associate professor over at Syracuse University. And I'm going to talk to you about the New York State Wastewater Surveillance Network today. It's an initiative that began in response to the COVID-19 pandemic and something that we hope to improve the public health of New York State and the health security of the state. You can reach me via email here with any questions you might have, and then I'm on Twitter here, where I post science Twitter primarily. And so before I get started, just an acknowledgement that this is a tremendous effort from a lot of folks. And so our funding has been initially from 2 universities and the seed grants that we received, and then working with the New York State, the Department of Health and the Department of Environmental Conservation. And we have a large team, a number of epidemiologists supporting the rollout, data scientists, program directors and management, the microbiologists, chemists, environmental engineers, and environmental scientists. It's a large collaboration and a lot of great folks working on this. The biggest thank you needs to go to our wastewater treatment plant operators. This would not be possible without them. They pull all the samples for us and send those into the lab. And so a huge thank you to anybody involved in the wastewater treatment industry and all the support that they've given. They've been fantastic. So here's the outline of my talk today. I'm going to talk about the purpose and the history of wastewater surveillance for public health benefit, and then going to talk about the New York State's wastewater situation, then talk about COVID-19 and wastewater surveillance, and then after that I'll introduce the New York State Wastewater Surveillance Network, and then talk a little bit about the future of what we hope for this network. So first, on the purpose and history of wastewater surveillance for public health benefit. Now, in terms of infectious diseases, we need to have good actionable data to understand what's happening in our environment, in our community. We need to be able to plan and to implement, to evaluate, and we need good surveillance data for that. The actual event of interest is transmission, the passing of an infectious disease pathogen from one person to another. But that is an unobservable phenomenon. It's just invisible. We don't ever observe that. And so we come up with a bunch of indicators. All right, these indicators are clues that infectious disease transmission is occurring or has occurred. And the most common indicators come from clinical surveillance. These include cases, right? If somebody gets sick, they can get a diagnosis and that can be reported. They include hospitalizations. Somebody goes to the hospital and that gets reported and as a hospitalization. They also include deaths. Now, these clinical indicators all have limitations, and also they all have biases. Particularly in our American health system, for somebody that contracts infectious disease, in order for them to become a case, they have to seek treatment and have access to care. And so we get these biases where people who don't seek treatment for whatever reason, or don't have access to care for whatever reason, they are not counted in these case counts. And this could be due to the symptoms not being too severe. If we have a minor cold, we don't typically go to the doctor, just might rest at home. They could also be due to things like a lack of insurance or a lack of financial means to pay for care. And so these case numbers then become a bit biased. Hospitalizations are a little bit less biased than case numbers, just because when people are really sick, they might likely go to the hospital. But we still have this lag where hospitalizations take time to develop. And by the time we see a spike or an increase in hospitalizations, there's a substantial amount of infectious disease transmission that has already occurred. And that's the same as deaths. Deaths are less biased than cases as well, because it is pretty finite. But then you also have this huge lag on deaths, and you can have deaths from infectious disease that take place months after the transmission has occurred. And so while our prevention policies need to be, in order for our prevention policies to have maximum benefit, they should be enacted when transmission is surging. We may not have the full picture if we depend on clinical surveillance, when we depend on cases, test positivity from those cases. And then if we look at hospitalizations and deaths, then we may be responding late to our surging transmission. And if we respond earlier, we can prevent quite a large amount of hospitalizations and deaths. And this is just in general for all infectious diseases. Now, wastewater presents an intriguing opportunity. Wastewater presents an intriguing opportunity to get an estimate of community level transmission. And there's a few benefits that wastewater provides. First, everybody poops, right? And it's not a behavior that is dependent on financial means. It's not a behavior that's really dependent on symptoms all that much, right? And so people use the toilet, flush the toilet, and that wastewater goes downhill to the treatment plant or maybe the septic tank. And so if we can sample that treatment plant wastewater or a community's wastewater in a systematic way, then that wastewater sample becomes representative of what is circulating in that population, contributing to that. And given that we have so many wastewater treatment plants, that becomes a very convenient place to pull a community level sample. And when I think about the comparison of what a wastewater sample means, it'd be similar to testing randomly maybe 500 to 1,000 people in a community. And so we get this single sample that represents the community, and then we can test that for evidence of infectious disease transmission, and we reduce a lot of the biases in the case data, right? So we reduce that, and then it's earlier than the hospitalizations and the deaths. There's not that same lag in most cases of infectious diseases, and so then we get a less biased, more timely estimate of community level transmission. Now, it's not a replacement for case data or hospitalizations or deaths, but it's a complement. And so we look at it, these data provide complementary understanding of that invisible phenomenon of infectious disease transmission that then helps guide public health response and planning. Now, if we look at the history of wastewater, of looking in wastewater for infectious diseases, the very first instance that I think about is I go back to 1854 and the epidemiologist John Snow and the Broad Street pump. And they had a cholera epidemic in London, and John Snow was able to trace all these cholera deaths back to a water pump on Broad Street. And they excavated the water pump, and they were actually able to find a cholera bacteria in a cesspool that was leaking into the water stream. Now, in the 1900s, mid 20th century, we start to see the application of testing wastewater for a number of infectious diseases, starting with typhoid fever. Right? So typhoid is caused by salmonella bacteria, and so then they're able to identify neighborhoods with asymptomatic typhoid carriers here in 1948, right? And identify the typhoid in wastewater in 1933. In 1940, poliovirus was detected in urban wastewater. 1955, Coxsackie virus and tuberculosis were identified. Then in the 1960s, wastewater began to be used to surveil polio, to give information on poliovirus. And now, if you're familiar with poliovirus, that the traditional surveillance, clinical surveillance, relies on acute flaccid paralysis. And so if somebody gets polio, they might get acute flaccid paralysis. And problematically, acute flaccid paralysis can be caused by things not related to polio. So to identify that polio is in a community, you really have to get a number of paralysis cases. Now, paralysis only occurs in 1 out of every 200 polio infections. 99.5% of infections don't develop paralysis. So by the time you have a surge in paralysis, you actually have a very large and substantial poliovirus outbreak. Then the wastewater helps give information about, all right, polio, we have found it in the wastewater. We know it's in this community. In 1998, hepatitis E is detected. 1983, hepatitis A. Cryptosporidium and rotavirus and norovirus in 2003 and 2005. Also in 2005, we start to see the application of wastewater surveillance for drugs. And so cocaine was the first in 2005, then morphine, marijuana, and MDMA, and methamphetamine in 2008. Opioids, 2014, prior to 2014, 2007, some experiments there. Also in the early 2000s, we see antimicrobial resistance measured in wastewater. And then in 2013, during the SARS-CoV outbreak, there was some documented in wastewater. And then in 2020, shortly after the SARS-CoV-2 pandemic began, in March of 2020, it was documented that in the Netherlands they pulled SARS-CoV-2 virus out of wastewater. Now, important in this history is the understanding and the perspective of epidemiologists. So prior to SARS-1, it was all fecal-oral transmitted pathogens that were being detected. And then antimicrobial resistance was kind of this odd one. And so from an epidemiologist perspective, even from my own perspective, prior to the COVID-19 pandemic, I thought of wastewater surveillance as this method to understand transmission of fecal-oral transmitted pathogens. So excellent for poliovirus. It is used widely in the polio eradication campaign. Excellent for things like hepatitis A and E, typhoid, of course, norovirus, rotavirus, Giardia, Cryptosporidium, all these. And then the SARS outbreak, and I didn't understand this at the time, but that was the first time that a respiratory transmitted pathogen was surveilled in wastewater. Now this COVID-19 pandemic, the SARS-CoV-2, we start to see wide-scale application of wastewater surveillance for pathogens that's transmitted through the air. Excuse me there. And so there's this huge paradigm shift that suddenly, all right, if wastewater provides us information on infectious diseases independent of the mode of transmission, what else can we surveil in wastewater? And some pending research from my team shows that there's a lot, right? Coronaviruses, Ebola virus, dengue, Zika, any fecal oral transmitted virus, HIV is likely, tuberculosis, malaria is likely. Right? We did a systematic review of 100 articles that were published by August 1st of 2020. We just looked for articles that tested for infectious diseases in wastewater. And these ones in orange, these are the viral families or bacterial or parasite families that we found in these articles. Internationally, we have this distinction of pathogens that they're infectious diseases of international concern. And that's this blue circle, right? And so coronaviruses, Ebola, dengue, Zika, polio virus are all international or viruses or infectious diseases of international concern, and they can all be found and surveilled in wastewater. And then influenza and HIV, we're hopeful that they can be surveilled in wastewater, but there hadn't been any definitive evidence from that in 2020. There's new evidence on influenza since then. Then these are worldwide. These in gray are the greatest burden of disease pathogens across the world. You have tuberculosis. It's a risk to wastewater treatment plant operators. Likely can be surveilled in wastewater. Malaria can easily be diagnosed in human stool, and so that can likely be surveilled in wastewater. Whooping cough, maybe. We'll have to look for it. And then measles is a maybe, and we'll have to look for that. And then the citation here. So that's the history and the purpose of wastewater surveillance for infectious disease for public health benefit. Next, I'd like to transition to what's the situation in New York State? What is this wastewater situation in New York State? And so in New York State, we have just over 600 municipal wastewater treatment plants. Right? And this figure shows each of these across the state. The size of the circle, each circle is a treatment plant. The size of the circle is relative to the permitted discharge capacity. So every wastewater treatment plant has a permit to discharge so many millions of gallons of wastewater per day. And the larger circles are much larger treatment plants that can discharge up to or even exceeding 300 million gallons per day. And then the smaller circles are less, and definitely these ones that are kind of grayed out, their permitted discharge is less than 1 million gallons per day. And so we see that, and this is understandable, right? They follow the population patterns. And so the major metro areas across the state, you have downstate here, Albany here, Utica, Syracuse, Rochester, Buffalo, this Binghamton down here. They follow the major. There's more wastewater treatment plants or larger wastewater treatment plants where there are more people. Right? And in terms of total population coverage across the state, 78% of the population is connected to sewer. So 22% is connected to private septic tanks or maybe community septic tanks. Now, from those 600 treatment plants, we have 202 of them, and these are all the ones that are highlighted are the darker circles. 202 of them are permitted to discharge at least 1 million gallon per day. And depending on the permits, wastewater treatment plants are required to sample their influent wastewater with differing levels, with differing frequencies. And in terms of infectious disease surveillance using wastewater, we want that pre-treated raw influent wastewater to test before it's been disinfected and any pathogens might be destroyed and things. And so 202 of these treatment plants, they have a permitted discharge of at least 1 million gallon per day. They are by law required to sample their wastewater, their influent wastewater at least once weekly and test that in the laboratory. If they're 5 million gallons per day, then they're permitted discharge. Then they have to do that at least twice weekly. And these ones that are at least 1 million gallon per day, they represent 90% of our sewer population. And so in terms of a full-scale coverage wastewater surveillance network, we don't necessarily need to we have diminishing returns. If we reach those first 202 treatment plants, that's 90% of the sewer population, right? That's 90% of the 78% of the state population. Those extra 400 treatment plants is just 10%. And then those smaller treatment plants, they have less personnel, less equipment to sample, and it's just a harder lift for them to contribute to the public health response or the infectious disease, the wastewater surveillance network. Now, in terms of comparing wastewater surveillance to clinical surveillance, one of the huge benefits for wastewater surveillance is that we only need 200 treatment plants, right? That's 200 tests. Even if we test that wastewater daily, that's 200 tests. It doesn't change. We don't need to test more people to get a more accurate picture of what's happening within the state. So I show here the daily COVID-19 diagnostic tests conducted in New York State from January 2020 through December of 2020. And so we see, the genetic sequence for SARS-CoV-2 was released on New Year's Eve of 2019, and the clinical diagnostic developers went into action, developing these diagnostic tests and started shipping. But you see, when we start getting diagnostic tests for COVID-19 in 2020, it was mid-March, and maybe late February, and by that time we were already seeing huge amounts of deaths in Italy. We were starting to see a huge amount of death in New York City as well. And so we just didn't have the clinical capacity because it takes time to develop these diagnostics and scale them up, right? We shut down in New York State, I believe, on March 17th. We shut down the schools. They didn't come back from spring break. And that was before we had understanding of where transmission was occurring and where it was not. Based on clinical cases, we knew where the hospitalizations were and where the deaths were occurring. And then over time, we scaled up these clinical tests, and in May, the test criteria, at least in Onondaga County, was relaxed, where previously you had connections to international travel. But you look at this huge, massive effort, this huge success story of New York State's clinical diagnostic testing scale-up, where we got up to 250,000 clinical tests per day. But that did take us a year after the genetic sequence was released. And then this dashed line, it's quite above 200, but that's to represent how many daily or weekly tests we would need to do to get the same level of information, community level transmission, compared to clinical surveillance. And it's just 200. And so if we had known, we didn't know this at the time, right? And this is not a criticism of the New York State response. For the future, it will be much easier to scale up wastewater surveillance for a novel pathogen, a new pandemic threat, than it is to scale up clinical surveillance. And just because of those numbers. All right. So now I'm going to transition to talk about COVID-19 and wastewater surveillance specific to COVID-19. As I do this, I'm going to pull a lot from my group's research, the team that I'm a participant on. And we've done, we started in central New York. The brilliance of Dr. Hyatt Green from SUNY ESF and Dr. Frank Middleton from SUNY Upstate. They began testing wastewater in central New York, and I was supporting them, trying to pull in wastewater samples and things. And by the end of 2020, we started in March of 2020. In mid-May, we were trying to scale as big as we could to anybody that wanted it in central New York and beyond. It's kind of just like a pull yourselves up by the bootstraps kind of thing. And then by the end of 2020, we had about 1,500 samples across mostly central New York. Now, as I relate what we found in the wastewater, I want to turn our attention back to this idea of transmission. Now, the current community risk metrics from the CDC, they are not really measures of transmission. They're measures, they incorporate hospitalization capacity. They're more measures for policy as opposed to what transmission is. And so I want to turn back to the indicators for community transmission that the CDC had used for the first couple of years of the pandemic, honestly, till just a few months ago. And so they categorized counties into low, moderate, substantial, and high transmission based on incident cases and test positivity. And so this low transmission level, this blue level, in the previous week, we had fewer than 10 cases per 100,000 population and less than 5% test positivity. Then we get up here to this moderate transmission level. Then we have 10 to 49 cases, 5 to 7.9% test positivity. Substantial is 50 to 99 cases, and 8 to 10% positivity. And then it's high transmission. If you have 100 cases in the past week per 100,000 population, and at least 10% test positivity. So remember, if you can, just keep that in your mind in terms of your frame. Now, when we look at that 2020 wastewater surveillance data, we take every time we get a wastewater test result, we first classify that result as, did we find SARS-CoV-2 RNA or not? Was it detected? And then second, was it detected below the limit of quantification? And in these studies, the limit of quantification is 5 genetic copies per milliliter. Or was it detected and at levels that were quantifiable, at least 5 genetic copies per milliliter? And so then those three categorical responses, then we look at how well those correspond to the low, moderate, substantial, and high transmission categories from the CDC. Right? And so this is a box plot. Each circle represents a wastewater sample. The size of the circle is relative to the number of people tested for COVID-19 in that sewer shed in the previous week. And so these larger circles, you have more people tested. Smaller circles, fewer people tested. And then we have three different levels: not detected, detected, below the limit of quantification, or quantifiable levels. Then on the x-axis, we have the 7-day COVID-19 cases per 100,000 population. So how many cases per in the last 7 days, right, per 100,000 population. And we have this low, moderate, substantial, and high categories that the CDC used to use. Right? So the first thing we noticed is that we have clear distinction and clear differentiation between these three categorical results: not detected, detected, and quantifiable results. This box plot here, if you're familiar with box plots, this middle line is the median. This square represents the interquartile range, so 50% of the observations are within the square. And this line represents the range, and then these circles represent outliers. And so most of the time, when we are not detecting COVID-19 in the wastewater, then we are within that low to moderate zone of COVID-19 transmission when we look at case data. And we do detect it, most of the time we're in that moderate zone, and then a little bit maybe that substantial. And when we quantify it, most of the time we're in that substantial zone. Now, if you remember maybe 6 months ago, the policy around masking, or the recommendations around masking, was that everybody should mask independent of vaccination status once you reach this substantial transmission level. And that substantial and high transmission level, that represents personal risk of contracting COVID-19 in my community, right? It's not risk of getting sick or going to the hospital for COVID-19. That's more related to my pre-existing conditions and my pre-existing immunity levels from vaccine and previous infections. But just of contracting COVID-19, we see that the wastewater data starts to line up extremely well. Whenever we had zero, or when we had non-detection, we had 40% of the time zero cases, right? A few with minimal cases, right? 90% of the time we had fewer than one daily case per 10,000 population, right? And so fewer, very much 90% of the time we're in that low to moderate range. If we look at test positivity, we see the same relationship, an even better relationship. And to me, this indicates that New York State was doing so well with testing, right? Great clinical test access. And so we see again this breakdown of not detected in the wastewater, detected and quantifiable levels in the wastewater. These levels according to the CDC based on test positivity: low, moderate, substantial, and high. And then we have the results. Every circle represents a sample, a wastewater sample. The size of the circle represents how many people were tested in that community, right? And so we see that this not detected, when we don't detect it, almost all the time, we're at less than 5% test positivity in 2020. That's before vaccines, before people were so sick of the pandemic they're not getting tested, before home tests. And so we're very confident that they're in that low transmission category. Even detected below limit of quantification, we're pretty confident that it's in that low test positivity. Once we get to quantifiable, then we see it's much more likely. These, you notice these circles here, that's just where we're not testing enough people, right? There's people, infections there that we're just not finding. And so we see that the wastewater results lines up with that transmission risk. And that transmission risk is the probability that a person will come in contact with the virus in their community. It's not the risk of hospitalization or risk of disease or risk of death. That's not the risk of transmission. And so wastewater is related to transmission risk. When we look at clinical cases, and I love this slide because this relationship was first investigated by one of our wastewater treatment plant supervisors in Cortland County, Bruce Adams, and then Dr. Hattie Green made the slide later. When we see that relationship between wastewater and clinical data, we see clear correlations. If we look at new cases, right, these incident cases, we have a correlation of about 0.41. Active cases is better. It's a correlation about 0.55. And the rationale, or the understanding of the hypothesis that active cases is a better correlator, or better correlates with wastewater levels, is that people, they begin shedding SARS-CoV-2 RNA in their feces, maybe before they have symptoms, maybe about the same time they have symptoms, but typically before they get tested. But then they continue to shed after they're diagnosed and even after they're recovered. So this active cases, this prevalent case measure allows for that post-infection shedding, and so it correlates much better with the wastewater data than just incident cases. When we look at across 2020 the temporal relationship between case data and wastewater data, we have different measures of incidence, test positivity, active cases. And then on this x-axis, we have lead and lag times, the number of days between wastewater sample and clinical sample, right? And so 0 days would be like the wastewater is pulled the same day as the clinical sample is pulled. So how many new cases on that day that is wastewater that are diagnosed on that day, not when it's reported, but when it's diagnosed. And then 3, the positive 3 to 5 would be the positive 3 here would be the wastewater sample date precedes the clinical sample date by 3 days. And that's what we find. There's about a 3-day lead time for active cases and test positivity is the best correlates with what's the level in the wastewater. And so we have this thought that, in terms of when access to testing is high, when test seeking behavior is high, as it was in 2020, then wastewater will precede the clinical data by about 3 days. Now, as test seeking behavior declines, as home tests are more common, and as testing access declines or decreases, then we would likely see a different temporal relationship and maybe a longer lead time for wastewater. But it does give evidence that there's some early warning or some early indication of that. And then we also see the incidence. The incidence doesn't provide a leading indicator for just incident cases. You have to use the active cases or the test positivity. All right. Now I want to transition to the non-detection of SARS-CoV-2 RNA in wastewater and what that means. And this is, my history prior to COVID-19, I worked a lot on malaria elimination in sub-Saharan Africa. And so we were always trying to understand whether we had actually eliminated. Is there actually no malaria in a community? Malaria is a mosquito-borne parasite. And so we know the mosquitoes are there. How can we be sure that the malaria parasite is gone? Now, we use this whenever we get a non-detection in a surveillance system, an infectious disease surveillance system, and for wastewater, for maybe we're doing mosquito surveillance, it could be clinical surveillance. We have two potentials. Either that pathogen is absent in the community, we call that freedom from disease, or that pathogen is missed in the surveillance network. And so if we don't detect SARS-CoV-2 RNA in the wastewater, then either that community doesn't have much risk of COVID-19 transmission, or our wastewater surveillance missed the risk that is there. And so we actually have an equation for this. We estimate the sensitivity of that wastewater surveillance network, and we're about 40% sensitive to detect a case, right? We use the number of consecutive non-detects, so every time we don't detect the pathogen in the wastewater, then that increases our confidence. That's kind of like flipping a coin, heads, tails, and every heads in a row, decreases your confidence that that's a fair coin, right? And then we use 1 minus that quantity to the nth power. And then that gives us our probability from 0 to 1 that that community is free from disease. And retrospectively, we apply this to Cortland County and Cayuga County in the summer of 2020. And so for both counties, we started testing wastewater in June, in late May, and in Cayuga County, we got detections, right? So we'll focus on this left side here. And on the y-axis, we have the probability that transmission is under control. That's that freedom from disease paradigm, probability that it's safe to go visit grandma, kind of things. And then immediate detections in Cayuga County and the city of Auburn, all through July. And so we don't have any probability, right? We know that there's COVID-19 in the area. Then the end of June, we get our first non-detection, and our probability jumps up. A single result, we're about 20% confident that it's not around. The next week, we get, again, non-detections. But then we get this string of non-detections, or then we get detection again. And then we get a string of non-detections consecutively. And over the course of about 8 consecutive non-detections where we're just not finding SARS-CoV-2 RNA in the wastewater, we get ourselves up to maybe an 80% probability that, hey, it's not around, it's under control. If we combine that with what the clinical data are showing, and here's Cayuga County, the daily COVID cases within that sewer shed, we see in May and June, we have a little cluster here. In July, a little cluster. But then through August, it's very minimal. We have maybe 7 cases in an entire month within that sewer shed. Now, the epidemiologists in the county health department will be asking, well, are we testing enough? Is there an outbreak that we're not finding? Right? And that 7 cases might be quite a stressful time, because that would be on my mind, we're not testing enough. Where is this? We got to find it. But the wastewater then would provide that peace of mind that says, they're not finding it in the wastewater either. And so maybe it's gone. And then that messaging becomes, take precautions, but take your kids to the park, visit your friends. Not a problem. Don't go crazy, but not a problem. In Cortland County, we started out with non-detection. So immediately we're seeing non-detection in the wastewater up through mid-July. And so immediately we're saying, all right, we're doing pretty good. When we see what's happening in June and July, we see, very little cases in this. And again, that confidence that there's not really transmission happening in this community. There might be in other communities, but transmission risk is a local risk. It's not, I don't care if there's Ebola. I care, but it doesn't affect my personal life if there's Ebola outbreak in Antarctica, right? And it's different from things like climate change in that way, where the temperatures in Antarctica matter for New York. The infectious disease transmission in Antarctica doesn't matter from New York unless somebody travels to there or from there back here and brings something. And so the risk, the local risk, is just gone. It's just not there. And we couldn't know that from case data, right? This absence of cases is extremely stressful in a clinical surveillance, because we know there's so many biases and so many problems with clinical surveillance. But then we get paired up with our wastewater data, and it's just eye-opening. It's like, oh, fantastic. Then we see then we get detection that just drops off. No probability that there's no COVID-19. And that corresponds to this cluster outbreak here. Right? Let me go back. That cluster got cleaned up, and so our confidence starts to rise again in early September, in August. But then in September it just drops out, right? And they had the big outbreak that was related to the colleges there. So this is my favorite piece of the wastewater surveillance network. This idea that we can use wastewater to confirm safety. And I talk to folks that are thinking about scaling up wastewater surveillance, and I say my favorite value, right, and especially in an emerging pathogen situation, is that you can actually confirm that a community is safe. That community is safe. It does not need to go into lockdown. It does not need to have more significant public health intervention in that community. And the public health messaging changes from stay in your house to stay in your community. And that the implications that has for mental health, for academic achievement, for schools, is huge. And wastewater can support that more precise intervention level, and very quickly in the case of COVID-19. All right, so now I've shown you a little bit some of the science around COVID-19 and wastewater surveillance that our team's done and what we can know from wastewater surveillance. Now I'm going to show you the network in New York State. And so our immediate goal is to scale at least one wastewater treatment plant to every county and bring them into the network. And this is our county coverage as of April of 2022. April 1st of 2022, since we've had more treatment plants come online. Now, important to note here, New York City is participating in wastewater surveillance with the National Wastewater Surveillance System as well as their own. And we're working on that relationship. They have the CDC considers the rest of New York and New York City different jurisdictions, and so the state health department is building those relationships and strengthening those ties, and we hope to bring them in. And then some of these other counties, they have wastewater treatment plants that are having maintenance. They have a large maintenance load, so some of them have been less able to jump into the system. But the immediate goal is to scale to every county, at least one treatment plant, and we can do more. And counties are doing more. Many counties are doing more. With that, this immediate goal is to train local health departments on how to use the data. And these local health departments, many of you just been slammed with COVID-19. So our hope is that now as COVID-19, as the workload around COVID-19 decreases, that you can begin to engage with the Wastewater Surveillance Network and to understand these data. We do weekly sampling in the Wastewater Surveillance Network in New York State right now. And that comes with weekly reports back to the local health department. These reports are given to treatment plant operators that are pulling samples and to stakeholders. And every county is assigned an epidemiologist, a CDC fellow, New York State Department of Health fellow, CDC and New York State joint. Every county is assigned at least one epidemiologist. And then you have my support and the other epidemiologists on the team support. Right. Then we have a public dashboard. And that's the goal, the immediate goal right now. Right. Here's the link to the state dashboard. It was developed by Dr. Mary Collins from SUNY ESF, and it's on her R-Shiny application. And there's two pieces of information that the dashboard communicates. The first is the estimated risk of community-level transmission. Again, understanding that's not risk of hospitalization or death or disease. That's the risk of contracting COVID in your community or coming into contact with COVID in your community. And then the second piece of information is the direction of trend. Is that risk increasing or decreasing? And I like to, these are two very different metrics, right? And they've been a little bit conflated throughout the pandemic as the same thing. But to understand this, I like to compare it to traveling in a vehicle. So in a car or a plane or whatever. You have your speed, how fast you're going, right? That's comparable to this estimated risk of community level transmission. Are we going 100 miles an hour? We might have high community level risk of transmission, right? If we stay at that speed, then we don't have any increasing or decreasing transmission. We just stay there. We're not increasing or decreasing our speed, which is our velocity, right? We just have zero velocity, but 100 miles per hour speed. Now, the direction of the trend is related to how we're changing our speed. Are we slowing down or speeding up? Right. And so we're going 100 miles per hour. We start slowing down. We might slow down to 80 or 70 miles per hour. We're still going really fast. We slow down to 40 or 20 miles per hour. Then we're starting to go slow. Right. Or we could even be speeding up. And so those are the two different measures of that the dashboard is trying to communicate. Is that personal estimated risk of community level transmission? So that's related to personal probability of coming into contact with the virus in the community. Excuse me. And the second is the direction of trend, whether it's increasing or decreasing transmission. Now, all the data are pushed to the National Wastewater Surveillance System, which is that's put on by the CDC. They have you can find their information at this link here, and so everything that comes through the state health department gets pushed to the national, and then onto the public dashboard as well. We don't post any building level wastewater surveillance. So I'm involved with Syracuse University, and a number of universities are doing wastewater surveillance at dormitories. That doesn't get publicized or publicly released. So I pulled this down last night. This was a screenshot from last night of the scale of the program and the status the county's reporting, right? And so we have probability of community transmission. We have substantial to high in most wastewater treatment plants participating in the network. We have some lows in Western New York. over here and some moderates down here. So the risk of coming into contact with COVID-19 in our communities is currently high, right? Substantial to high. Some of these are grayed out. We're just working. One of the challenges of scaling this network is we have no fewer than 5 laboratories with different methods, all analyzing wastewater, and we have to pull them together into a single metric. So we're still working on some of the data analysis on that end. So this is the probability of community transmission. And there's a little tab up here where you can switch from community transmission to direction. And this is the 2-week trend, right? So the current probability of coming into contact with COVID-19 in our communities is high. And is that going up or going down? And so this is a blue-orange scale, with blue being going down, orange being going up, way up. This is based on 2 weeks, right? The past 2 weeks of data. So if we're sampling weekly, it's based on 3 data points, and it's a linear regression fit. If we're sampling twice weekly, it would be based on 5 data points with a linear regression fit. So, but you have here, quite a few areas are going up, right? Across upstate New York. So we're at a high level, and that is increasing. Some areas is coming down. We're at a high level, as the 2-week trend shows it's declining. And some areas, here is relatively stable, which was good because these were some of the low areas. The other thing we get is this time series. And infectious disease surveillance data gains strength over time. And I can't reiterate enough how important it is, how much more we know today in certain communities that have invested in this system for a year or more. Other communities are coming online. We're getting, the big scale up at the state level happened in January, February, and the first use case was we thought that the first use case of wastewater surveillance would be to confirm the decline of transmission, to confirm that we were through the Omicron surge. And we started to go that way, but now the use case is to say, all right, well, we're back, transmission is back up. And so the use case is that, yeah, there's a high level of transmission across much of the state. But this is Steuben County, the wastewater treatment plant of Bath. You can, in the maps, you can click on any of those treatment plants and you get a time series like this. Right, and so in the Bath wastewater treatment plant in Steuben County, they started with the network in April of 2021. So we have about a year's worth of data. And so we saw the decline of transmission from April through May, the summer of 2021, where there was minimal transmission, even some non-detections, but these are detections below the limit of quantification right here. And then it started to go up. We saw that Delta wave, and then the Omicron wave and peak. Then it comes back, and then it's come back down, and now it's going back up. All right, and this is the 2-week trend. So this relates back to the blue-orange color scheme. I'll flick back there. So this color scheme, right, relates to a 2-week trend where we look at, all right, what's happened in the past 2 weeks? We fit a linear regression line to that, and then and the slope of the line gives us that measure. Now, a couple of things. These wastewater data are much more, if you've seen other wastewater data from BioBot or from other folks, that you see a lot spikier, a huge surge in Omicron, and this doesn't show that same huge surge. So we use a different measure where we log transform the SARS-CoV-2 levels, and then we standardize that to our human fecal indicator CRAS-phage. And what that does is it reduces the peaks, and it works better at low transmission levels, less at high transmission levels. And you can switch between raw genetic copies or this intensity of SARS-CoV-2 measure to see the difference there. But if you use the raw genetic copies, then you get these really high exponential growths of Omicron and Delta and things. So that's the state dashboard. That's the state network. If you have questions about the state network, I am here. I'm available. And we have a team here, and we'll support you, get you going, talk to you about what status your county's at, and help you out that way. All right, so the last bit, we're almost done. It's been a while. The last bit is, what's the future of this New York State Wastewater Surveillance Network? And so as I talk about the future of this, we'll break it into immediate, pending upgrades, and future directions. So a pending upgrade, what we're working on right now is we're working on forecasting COVID-19 hospitalizations from wastewater, right? And so we know the wastewater provides us a really good estimate of transmission risk, and then we think we can use that combined with population level immunity and the age structure, underlying health condition of the community to then get a forecast of hospitalizations. We hope to have this ready for local health departments and policymakers here in the next month, right, by the end of May, if not sooner. This figure shows some work out of Greece, out of Athens, and then you have this left axis is the blue, right, is the level of SARS-CoV-2 RNA found in wastewater, and then the orange is the number of cases. And you just see it, it predicts it. It predicts it really well, and we see the same thing in New York, and it does that for hospitalizations. And so that's one pending upgrade. We hope that to be of immense value to county health departments and to policymakers, the state health department. So that'll be good. Another pending upgrade is genetic sequencing, and so New York State is probably the best state in the country for genetically sequencing its clinical samples. And then we want to bring that expertise into the wastewater samples. And so this is an example of a dashboard from Minnesota and their genetic sequencing of wastewater samples to see what the dominating strains are. So you start to see here you have alpha, beta, gamma variants in green in June of 21, July of 21. Those get replaced by Delta in the fall. And then in January, the Omicron BA1 surge, and then now the BA2 surge. And these levels are not the levels of RNA, but just the percentage of lineages, the percentage of variants that were sequenced. And so, quickly go to 100%. And we can do this at a community level, right? So we can say, as this gets incorporated and we build this, we can then say, all right, well, Syracuse, you have this variant circulating, and Watertown, you have this variant, and Long Island, you have this other variant. And that's important not only for public health messaging, but also because some of the treatments differ in their efficacy based on which variant it is. And so that's a pending upgrade, and we hope to have that online here shortly. Now, a future upgrade that we're still waiting to see about funding for is we want to sample more treatment plants more often. So I think we have about 80 treatment plants currently that are regularly sampling in the network. We want to bring that up to at least 200. And we want to do, and right now most of our treatment plants do weekly, and we want to bring that up to twice weekly. And so I go back to this map. This is kind of what I consider the full coverage wastewater surveillance network for SARS-CoV-2 in New York State, where we have every treatment plant with at least 1 million gallons per day permitted discharge capacity participating and sampled twice weekly. And then they have the genetic sequencing going on as well. And so we hope to get here. And we'll see about where funding goes. This is more August, September. We'll hopefully roll this out August, September if we're successful. And but if your county or your community wants this, it's at a community level, it's not that expensive. We have we could, if you're interested, we can talk about it. But maybe $10,000-$20,000 per year for a community to do twice weekly sampling. Maybe it's a little bit higher. No, it's about $20,000 per year for a community to do twice weekly sampling. Another future upgrade we have is we want to expand the infectious diseases, right? Immediate response, immediate goals to support the COVID-19 pandemic. We know that's not the only infectious disease out there, and we know that there's other pandemic threats that are lurking. So this is the third coronavirus to jump over from animals to humans in the last 20 years. It's the third pandemic in my lifetime. We should probably expect maybe another coronavirus. Hopefully it won't be the same pandemic, but would likely another pandemic as well. And so we want to have this system ready to go and primed so that when there's an alert that there's something that emerged somewhere, we can immediately point the system to look for that thing. And so we're looking at more infectious diseases. That helps us to understand the interaction. Our immediate targets are antimicrobial resistance, hepatitis A, influenza, norovirus, and RSV, respiratory syncytial virus. And we have good evidence that around RSV. We know for a long time that antimicrobial resistance, Hep A, and norovirus can be surveilled in wastewater. But the groups out of Michigan, Chris Wigginton's group, they've shown that they can track and surveil influenza and RSV in wastewater. And this shows influenza A, right? The clinical cases and positivity here, and then the wastewater copies per genetic copies per wastewater here, right? The other future upgrade that we hope is to start doing opioid surveillance and surveillance of other illicit drugs. You know, this opioid crisis that we're in is one of the great public health crises that our state and our community face. And opioid overdose deaths are just staggering. Wastewater surveillance, we know that we can measure levels of opioid use in communities. And so we hope that we can provide increase and a benefit to local health departments and to treatment groups, to communities, to better understand that opioid burden, right? The opioid burden is hidden. We see glimpses of it with overdoses and hospitalizations and deaths. But wastewater can unveil a lot of that burden. And so, we're doing a pilot right now with a number of counties, and we hope to scale that up to maybe 100 treatment plants later this year if the pilot's successful. And that would then provide continuous or continuous data stream, a monthly data stream of estimated opioid use in a community, which would then help plan, advocate, and evaluate policies and interventions and try to bring this burden down and save lives. All right, last slide before the thank you. When I reflect on the COVID-19 pandemic, I think, how can we make our communities safer and stronger, more resilient, ready to face a pandemic threat? Our health security was breached. We lost liberty, we lost life, we lost a lot during the pandemic, all of us. And so that health security was breached, and I hone in on this idea that, is our infectious disease surveillance adequate and ready to make sure that we don't go through this again? Now, the pillars of infectious disease surveillance that I look at that we might improve, wastewater surveillance is one of those. Right? It's not the panacea to infectious disease, but it is one pillar that we need to have a robust wastewater surveillance network to make sure that we don't have another health security breach to the same magnitude we had with COVID-19. Other pillars include genetic sequencing of viruses. We need to better electronic health records. We need to be able to link hospitalizations with pharmacies and primary care more easily. And then we got to figure out a contact tracing core. We pay firefighters a lot to sit around, and I'm happy to do it. If I have a fire, I want that firefighter coming. Those fire trucks, they're the cleanest vehicles in the state. And I'm happy. I'm happy to pay taxpayer dollars for that. I'm happy for my tax money to go to firefighters because of the huge good that they do. We don't have that same perspective for public health, right? So infectious disease contact tracers, we don't have people continuously training to the level that we would need in that pandemic. And so we need to rethink, in terms of how do we get a contact tracing core and infectious disease response units continuously training. But in terms of wastewater surveillance, that's one pillar. We want this system robust. A robust system is continuously training, continuously working. And so we need to have continuous operations, right? It needs to be able to confirm that communities are safe. It needs to be able to confirm that there's an increase in risk, right? And hopefully we can do that together. So, giant thank you to you for listening and to having me here at New York State Public Health Association. Thank you to our funders who've been working with the State Health Department, the Department of Environmental Conservation. They've been amazing. Dan Lang, Tabassum Insaf, Mohammed Al-Azawi, and Roger Sokol at the State Health Department are definitely amazing. They've done such amazing work with this wastewater surveillance network. Here's a group, the early team, and then if you're interested in some of the science that our team's produced, here's a number of papers that have been published over the last year and a half, last 2 years now. But thank you.